Am I on mute now?
She's this way, isn't
No.
she? It's fine.
Sorry, apologies everyone. We'll just give everyone a couple of minutes to join the meeting.
I'm just checking, Sam, whether our expert by experience has joined the call yet. I'm just conscious it would be good to make sure she's on before we start. That's okay.
So
Not yet.
You're going to talk, Vic, and I'll share the screen.
Just give everyone one more minute to join, then we'll start.
So I've deliberately not got my phone with me, but I'll just check to make sure that she's managing to join us. Bear with.
Thanks, Catherine. Welcome everyone. We're just giving a couple of minutes for everyone to join.
Yeah.
We'll be joining shortly.
Yeah. again, we can add that.
Hi everyone. We'll be starting in
So
1 minute. Sorry, I'm just waiting for Catherine to return, and then hopefully we'll be able to start. Thank you.
Jen, it's
Good to go, Jem.
but like Lisa said,
Thank you. Welcome everyone. This is the Dementia and Cancer webinar. Just a bit of a excuse me, my slides aren't working. There we go. Housekeeping. Welcome and thank you for joining us today. We're going to be starting shortly with the webinar, but just a bit of housekeeping first. The webinar is being recorded, and we're hoping to be able to put that somewhere where you'll be able to access it. Audience cameras are turned off and microphones are muted as well. But please can you share any comments or questions in our Q&A section? It's in the top right hand side of your screen. So if you look at the top of the screen, there'll be a Q&A and you'll be able to ask any questions there, and that will be monitored through the process of the webinar. And at the end of the webinar, we'll pull that together in terms of what questions we might be able to answer. Hopefully we'll have enough time to get through them. So just as a way of introduction, my name's Jen Kelly. I'm one of the Senior Transformation Managers at Cheshire Mersey Cancer Alliance. I'm going to introduce my colleague first.
I was going to say good morning, good lunchtime to everyone. I'm Catherine Morgan-Jones. You can see my title. I work for the End of Life Partnership. We are a charity based in Cheshire, and as the name suggests, our organisation is all about improving palliative and end of life care, irrespective of where people are receiving that care and the conditions that they are living with.
Thank you, Catherine and Katie.
About how we do it.
Hi, I'm Katie Lobley. I'm a clinical psychologist and I'm based in the cancer psychology service that covers Liverpool, Royal and Aintree sites as part of Luft.
Thank you. So this is just the agenda that we're going to get through today. When it moves, sorry. So we've first of all got our expert by experience, Sheila Harvey, who we've pre-recorded her experience, and we're going to show you this morning as a bit of a scene setting and context setting as to why we're talking about dementia and cancer as a dual diagnosis, the importance of that. We've also got some context for the project, overview of the project, the findings, and also the recommendations. And then obviously at the end of the session, there'll be an opportunity to look at the questions that have been asked by the participants and hopefully be able to respond to those. Just a bit of an overview of today. We've got a very mixed profession within the meeting. Oh, I can see some hands up. I do apologise.
And that will be then.
Jen, I think it's about background noise at your end, unfortunately.
Okay.
Document as well.
Okay, so I do apologise for that. I'll try and move in a minute. We'll start with the patient video if that's okay. As I said, there's a mixed profession in the room. So we've got some professionals and we've also got some of our experts by experience. And we're really lucky to have those involved in the meeting today. So I'll start the video and then obviously Catherine will then pick up in terms of the rest of the information. So give me 1 sec. It takes a little minute to start the video, so just bear with, please.
Send me that would be good. Yes, it's easier rather than us go through it now. We could just go to a little list of all the such sections and what we think would be best to do for each section. Would that be good for you? Yeah, and would that be Live, yeah, it's fine.
Apologies all, it's just taking a little minute to reload. Just give me 1 second, I'll try and restart it.
It was palliative care from the word go, and there's nothing they could do. So then the process started of what was going to happen to us, and how they was going to help Colin to get through his journey. The next thing is he started not feeling quite himself, and he kept getting a little bit fussy with his words and what he was doing. So I went to the doctors with him and said, is there any possibility that Colin could be mixed dementia or have, you know, problems? So they decided to send him to see somebody more professional than them. And we went to the appointments, and he got told, you do have mixed dementia. Colin had to have stents fitted in because he'd had nephrostomies before that, which didn't agree with him. He kept having infections in his back. So it come to a point where he had to have his stents changed. And we got home, and he started complaining that he was in pain. Get him out, I'm in pain. And he tried to rip the stents out himself. So I called an ambulance. And unfortunately, Colin again didn't like being there. And I had explained to them that he did have terminal prostate cancer and that he was also mixed dementia. One of the nurses came in and said to me, Sheila, how long have you been looking after your husband? And I said, 8 months. How are you coping? I said, not very well. Now, up to then, really nobody had asked me how I was coping. The next thing is the sister of the ward came in and said, of A&E, she turned around and said to me, we put a section 4 on him. He won't be coming home. Because he's a danger to himself and he's a danger to me. But to me, it was just Colin. It was another Colin. We used to have 2 Colins. There was a Colin that was lovely. And then there was another Colin that used to get frustrated because he couldn't understand what was happening to him. They kept him in for 2 months. And then they had to find somewhere else for him to go. So they decided that Colin, with his dementia, went into a dementia unit. And this is where it got even worse, because Colin kept trying to escape and they couldn't cope with him. So he had to be moved to another place. Again, another dementia unit. No mention of his cancer. That had been forgotten. And consequently, he moved to another unit. And again, Colin used to get frustrated and everything. And so they turned around and said, right, okay, well, because he's got these complex needs and everything, they were going to have to move him again because they couldn't cope with his complex needs. I was ringing people up and wasn't getting very far. So I decided I don't drive, but I'm just going to go and start pleading with people, you know, and see if we could get him somewhere where he'd be settled and happy. And was told by each and every one of them, I'm sorry, lovely, but you should never have been sent here because we don't do it. We don't have the facilities for people with dual diagnosis. Eventually, the social worker and myself finally got together and finally managed to find Colin somewhere else to go. So we went there and thought he was settled. But in the end, he didn't want to stay there. He wanted to come home. That's all he ever wanted to do. I want to come home. We had a meeting. And at this meeting, my daughter was there. His consultant was there, Marie Curie, and a representative from the home. And it was agreed that Colin had to be moved somewhere else. And I was tired. I was so tired. And I got told I needed time out because I'd been looking after Colin at home, and then I was at the hospitals, and then I was at the care homes. It got to the stage where I needed time. I had to have a week to myself. And just as I was going to go away, they said they thought they'd found somewhere for him to go. And I said, but I'm going, I'll cancel my holiday. No, go on your holiday, it'll be fine. So, as I say, I did go on that holiday for a week. I came back and I walked in the room and I thought I'd gone to the wrong room. He deteriorated that badly. They'd stopped feeding him. They'd stopped medication. Didn't do much for him. On Saturday the 15th of June, I got a phone call from the care home that Colin had finally ended up in to ask me if I could go to the chemist and pick up Colin's prescription, which they needed. I thought it was a bit strange, but I said, yeah, of course I will. Yeah, of course I will. They didn't have enough staff. I said, right, okay. The pharmacist looked at me and said, Mrs. Harvey, do you know what the prescription is for? He said, I'm sorry to tell you, it's the end of life pack. They didn't tell me. And then suddenly it hit me. And I broke down in tears. So my daughter spent some time with her dad. She left. And I was sitting on this rickety old chair and my back was aching. And I was getting tired because I got so emotional and so upset. I didn't want Colin to see it. And I just said, right, okay, love you, you're all right. And he went mumbling. And I said, right, love you, I'll see you tomorrow. I went home, sorted my 2 dogs, tired, went to bed. The next thing is the phone rang. It was the home to tell me that Colin wasn't very well and that they'd had a district nurse out to give him an injection for his pain. And I said, oh, right, okay. She said, but he's okay now, he's sleeping now. I said, okay, fine, as long as he's all right. I said, but you will ring me, won't you, if you do need me? Yeah. And then within half an hour, I must have dozed off. And then I get the phone ringing again. Will you come in, please? Because Colin's deteriorating. I said, okay, I'll be there. So the taxi turned up. And he was taking me down. And then my phone rang again. It was a home again. Mrs. Harvey, we're sorry to tell you that Colin's passed away. I'd looked after him all that time at home. And then he gets let down by nursing homes, which should be looking after him and didn't. So this is why I made a promise to myself that I wouldn't let anybody else go through what I went through and Colin went through. People are people. It doesn't matter whether they've got Alzheimer's, mixed dementia, or whatever cancer it is. And the words I always use is they're not a jigsaw puzzle. You can't take one piece out, see to that, and leave the rest of it. They're a whole person and have to be treated as a whole person, because people need to realise, social workers, doctors, hospitals, all need to come together and unite as one and start saying, yeah, this is not acceptable, because the patients deserve a better death and the loved ones don't deserve to be put through what they get put through. And they've also got to think there are people what are on their own, haven't got somebody to fight their battles for them. And this is why I want people to take notice now and start thinking and acting. And that's mine and Colin's story.
Okay, so apologies that we started slightly late, but the reason we started slightly late was to make sure that we had Sheila on the call. So Sheila, who you've just heard from, was our expert by experience for this project. And I think you'll all agree that it was really important that she was able to be with us, to be part of you sharing that story with all of you. So massive thank you to Sheila for sharing her story. Need to acknowledge that, you know, you'll have picked up on the dates. This is only a year ago for Sheila, so it's still very much fresh in her memory, and you've heard the emotion in the story. So we just want to acknowledge, as I say, our thanks to Sheila, and also just to say, you know, there may be things within what Sheila said that maybe felt a little uncomfortable, but that was Sheila and Colin's experience. So, you know, that was the reality for them at that moment in time as well. So thank you again, Sheila. There's a couple of things we just want to draw out from what Sheila's just said. Actually, there were the two key things that Sheila's asked me to get across. Number one is that image of the jigsaw puzzle, that we need to see people as a whole person holistically, not just individual components. And obviously, when we're talking about dual diagnosis, that's exactly what we're talking about. And then the other thing is just how complex it is to navigate your way through one part of the health system. So whether that's for cancer or dementia, but when you're trying to navigate two at once, just how complicated it is. And I think for professionals on the call, it's just a little bit of a reminder that if you're not embedded in it day to day, just how tough that can be. Okay, so I'm going to move us on, if that's okay. We're just going to start with some context for the project before I hand over to Katie and Jen. So for people who are not from Cheshire and Merseyside, so we have a total population here of 2.7 million people. And in terms of our populations with cancer and populations with dementia, we've got some figures for you here. So I won't read those out in loads of detail, but you can see obviously we've got significant populations with both conditions. What I would like to just highlight with dementia is that the number of people with a diagnosis is about a third lower than the people estimated to be living with dementia, because we've got a significant gap in terms of that dementia diagnosis rate as well. And then the other key thing to highlight with both cancer and dementia is that the biggest risk factor for both of those conditions is age. So the older you are, the more likely you are to develop one or both of these conditions. And actually what we do know from research by Leeds Beckett University is around 7.5% of people who are age 75 plus will be living with both cancer and dementia. And as we know, both of those pathways are complex. Treatment can be complex, lots of decisions. So if you're dealing with both at the same time, that's, well, at least a double whammy, if not more. So that just gives you a little bit of an indication about our population here in Cheshire and Merseyside. Thanks, Sam. So in response to the experience of people like Sheila and Colin and some of that data, the scoping project was established by Cheshire and Merseyside Cancer Alliance. The project had two aims, really. One was to scope the level of need, what was already out there for people with a dual diagnosis, what best practice we might be able to learn from elsewhere, and also just to talk to professionals about how confident they currently felt about dealing with people with a dual diagnosis, if indeed they'd come across it, or if they'd sort of given it a great deal of thought. So we had a whole load of scoping to do in terms of people with a dual diagnosis in this part of the world. And then based on that scoping and all of the findings, we were asked to co-produce a set of recommendations about how we could actually improve care for people with a dual diagnosis and their carers, and how we could improve that across Cheshire and Merseyside. Thanks, Sam. So just to give you an idea about how we approached the project, project manager talking, you can tell, can't you? So first thing established really was that our governance arrangements and our delivery arrangements. So we had a small project team, which included included clinical leads for both cancer and dementia. So Katie was our clinical lead for cancer, and Sarah Jones was our clinical lead for dementia, Sarah being an Admiral nurse. I'd also just like to credit Poppy and Aleri, who were our trainee and assistant psychologist, who joined the project team as an absolute bonus and brought real kind of insights as well. And then from a governance point of view, we also had a wider steering group, which included Sheila, who you've just met as our expert by experience, and the Cancer Alliance as well. So once we'd got the team up and running, we started with our sort of desktop searches, literature review, looked into best practice, all of those sorts of things. And then a lot of that work then informed our engagement with clinicians and with people with lived experience, so experts by experience as well. In terms of the engagement, that really was the bulk of the work that we did, was going out and finding out what people's experiences were. We wanted, from a clinical point of view, to be able to do that across as many people as possible. So we developed some online surveys to get that breadth of feedback. But then we also held a lot of one-to-one or small group meetings and discussions to get the real depth of insight as well about what people were experiencing, some of the barriers, some of the challenges, and so on. And then likewise with our experts by experience, we met either face-to-face or online just to hear their stories. Essentially, we produced a huge amount of data and an awful lot of themes, which Katie's going to run you through. And then the next stage, once we developed those themes, was to test those out with a group of stakeholders and co-produce the recommendations from that. So in terms of the overall approach to the project, that's pretty much the process we followed. It always looks very neat with hindsight and very kind of managed. It was slightly more chaotic than that in the middle, but essentially a huge amount of information, which then led to the themes and the recommendations that we're about to share. So at that point, Katie, I'm handing over to you.
Thanks, Sam. We can move on to the first slide. Thanks. So as Catherine's highlighted, we're looking at a level of need of about 18,300 people in Cheshire and Merseyside with this dual diagnosis. We know that's an underestimate, and also that's not including people with cognitive impairment rather than a clear diagnosis. We also know there's barriers to diagnosis as well around dementia. And we're looking at an increase in this kind of presentation and this level of complexity. Okay, Sam, are you okay? Can we move on? So as Catherine said, we went about gathering information to try and compile it into a report and make sure it had a sense of breadth. So the online staff survey has the benefit of being able to get staff views without a huge time demand, rather than the one-to-one conversations, which were usually a minimum of an hour discussions with people, and a lot of time given by patients, families, carers and staff to this project. What we found, if we're thinking about the breadth of and spread of people contributing to this report, was that we did have a real balance between input from community sectors, from care homes, from trusts, and from people with lived experience. Often professionals were contacting us not because of their professional experience and wanted to contribute, but because of their personal experience, lived experience. So there's a real mix of contributors to the report, and people coming from the dementia sector as well as from the cancer sector. The online survey was more dominated by trust staff and professionals, but that wasn't true of the one-to-one conversations we had. So next slide, please. In order to theme, we got a wealth of information. We got a huge amount of information and a lot of stories and a lot of overlap between different stories and then different angles. So in order to try and condense them into something that felt meaningful, we've grouped the findings underneath the 6 ambitions for palliative and end-of-life care, the national framework. So these themes were whether care is coordinated, whether communities are prepared to care, whether a person feels their comfort and well-being are maximised and that they're seen as an individual, they have fair access to care and feel that staff are prepared to care. So those are the idealised care settings. Thanks, Sam. So under ambition 1, the things that we were hearing are that, and then this seems like the biggest problem, and it speaks to the complexity that's already been mentioned and that Sheila's talked of, is the difficulty coordinating care when it's this complex. And we focused on cancer and dementia, but really people were talking about a multitude of physical health problems and financial and social problems that also make the complexity of coordinating accessing care incredibly difficult for these people with a dual diagnosis. The complexity lies in so many different layers. There's the complexity of navigating note systems, of sharing information, of different trusts providing different information, of needing coordinating care, but having to coordinate services across different organisations, even different sectors across social care and healthcare, and a lack of clarity about how that is coordinated. There was also experiences of people finding barriers, such as very practical, not being able to access notes, not being able to access medication in certain trusts, and a sense of silo working and a specialism, a specialist services not necessarily being as confident outside of those services. So when we looked at the data from the cancer professionals, there was an online survey, there was less confidence than people in care homes when working with dementia, which is to be expected given that some of those staff don't have a lot of regular contact with people with a diagnosis of dementia. But it adds to the lack of coordination and knowledge around the dual diagnosis and the complexity. Thanks, Sam. In terms of the communities being prepared to care, we heard a lot about the burden on carers. Understandably, they're the people that can't turn off the screen at 5 o'clock, that they're still living with the support needs of their person, that their loved one, and how isolating this can be, especially when it's quite a huge time demand, it's confusing, it's complex. Filling the gap of the lack of coordination is often a carer, a family member who is running around trying to make appointments and navigate different hospital trust systems. There's lots of sources of potential confusion around pathways, access to services, medication, and even who to contact for support. And a lot of the community support is provided by third sector and voluntary sectors, and that's incredibly fragile and vulnerable to fluctuations in funding. So that was really problematic for some people being able to access admiral nurses in the region and other people not being able to have that support. Thanks, Sam. Again, this links back to the initial issue of barriers, blocks, and problems of coordination that arise from complexity, which has a really direct impact on whether people can even access the medication or the care that they need. Some concerns in physical health settings about we can't access the psychiatric medication that was necessary just due to prescribing difficulties, and that led to quite a lot of barriers and blocks and hurdles having to access that medication. In the meantime, the patient doesn't have access to it. And then similarly in dementia care settings, staff not necessarily feeling as confident with the physical health needs of patients with cancer, and that causing a huge amount of stress, anxiety, and difficulty and even moral injury for the staff having to support those patients, knowing that they couldn't access the right support. And again, speaking to the complexity of medication, the issues around prescribing in one context, not necessarily not necessarily feeling confident with the prescriptions being appropriate for all conditions, and some of the interactions between that, needing access to specialist advice, pharmacological advice, which I think is available, but again, not people not always being confident about knowing where to get that advice. Thanks, Sam. In recruiting staff views about decision making and best interests and where the individual sits in those decision making, there was some level of uncertainty expressed and a desire for further support and training around how to support patients with cancer and dementia in their decision making around accessing assessments and treatment and any interventions. Where we encountered an Admiral nurse being embedded in cancer services, this appeared to be much more well supported, because there was a clear role and there was a clear set of responsibilities lying with that person in responsibility to best interests, and then a more individualised approach was possible there. We had a lot of carers voicing their experience of not feeling involved in best interest decisions and feeling that they weren't able to advocate for their loved one in that way. And also the difficulty of services that services experience in terms of the pressures and the monitoring, and that makes it very difficult to provide the individualised care. So for instance, longer appointment times for some individuals or adjustments that might be really helpful are in direct conflict with the performance indicators that are required for services sometimes. Thanks, Sam. There were concerns voiced as well about the accessibility of care. So, for instance, people not feeling able that concerns were communicated well, or that symptoms and pain were being picked up on because of communication issues. Possibly there was some expression from staff that they wanted more support and training around how to communicate and how to pick up on different ways of communicating pain and symptoms in order to meet physical health needs, because that could be a barrier. And assumptions that people may not have had support around decision making and quality of life decisions. So there's also physical barriers we came across a lot. The hospital environment's not often being dementia friendly and being really inaccessible because of that. Difficulties with signage. Visually, we found the hospitals sometimes when we visited them really overwhelming, but also little things like the toilets and the taps and things just not being very accessible and not being dementia friendly, and that all becoming a massive burden on somebody coming for what is also a really difficult appointment as well, and accessing cancer care. There's also the issue of stigma and anxiety, which can potentially be brought up by some staff. Some staff were identifying stigma and accessibility around either dementia or cancer for some patients, and that being a further barrier. Thanks, Sam. Staff were all prepared to care. The staff that we met were all very invested and prepared to care, but also spoke of their distress at not being able to because of all the structural barriers, and also because of lack of knowledge, access to specialist knowledge, and other pressures, leading them to be unable to provide the care that they think that they would have liked to in an ideal situation. They identified needs for training, so we've got a specific set of recommendations around what training they felt would be helpful to support them in different areas. We also noted that there were very different training needs for different staff groups, and that needs to be individualised rather than just a general dementia and cancer training, because people have very different levels of experience and very different presenting issues that come up. Thanks, Sam. So as a summary, if anybody, I'm assuming that everybody on this meeting has an investment in the care of people living with cancer and dementia, and so what you're hearing today is unlikely to be surprising. I think the report, we aim to pull a diverse group. We heard a lot of replication, but pulling together a diverse set of findings from services that don't typically work very closely together. But also hearing a lot of the pain that people have experienced was really difficult. Also, hearing the distress of staff about not being able to provide the care or having limited resources around providing the care that they needed to was really difficult and important to recognise, but also the structural complexity of providing this care, that there are a lot of barriers, not just at the individual caring level, not just at the individual patient level, but at the organisational level and the wider system. There were also, we did hear of examples of committed staff going above and beyond for some patients and for some experiences, and that was really incredible to hear. I think the report have highlighted some of those positive experiences and what a difference that made to those patients. So I think that's our summary. Thanks, Sam.
Thank you, Katie. I'm going to pick up on the recommendations from the scoping project that we had. So just to give you an understanding, this is the key of the recommendations. So we looked at resource implications, whether there was a low, medium, or high resource impact from some of the recommendations. And we also looked at timescales for implementation, short term being within the next 6 months, medium term 6 to 12 months, and then long term 12 months plus. The recommendations are broken into different sort of organisations or areas to sort of focus on. The first 4 are around things that the Cancer Alliance and partners could potentially look at. So the first recommendation is access to additional dementia expertise for cancer MDTs. So this is potentially looking at how we can utilise recommendations and good practice from things like the Royal College of Radiologists guidance on cancer MDTs. Although this is guidance for frailty, there's potential that the could be applied to dementia as well, those with a dual diagnosis. And there's particular options around how we can support better access to dementia specialists through MDTs. And that could be things like having actual specialist people involved in the MDTs, utilising existing experience. So for example, if a trust has an existing admiral or specialist dementia nurses, how they might be embedded or utilise them within existing MDTs. There's always obviously different options in terms of external arrangements, collaborative arrangements with service level agreements for those who have got the expertise and to bring them into the trust, to the obviously more sort of costly model of recruiting dedicated dual diagnosis individuals to support. Obviously there's considerations here around, you know, clinician buy-in, good practice, and also limited, you know, where there is limited support, how might you look at how you can get dementia support within cancer services. There were some really good examples. So for example, Liverpool University Hospitals, they've got a peri-operative care for older people, a POPS service that had some really good application in there. And then there's also things like the frailty assessment in oncology services through the Royal College of Radiologists, and also the Centre for Perioperative Care guidelines for cognitive needs during surgery. So there's some sort of good examples of information that can be utilised or practice that can be utilised here. The second recommendation is around additional advanced training for professionals. So this is improving on the existing training that people have around things like mental health capacity, best interest decision and things like that. So thinking about an education programme to increase the understanding of cancer to dementia professionals, but also of dementia to cancer professionals. And the recommendation here is about how actually we can utilise dementia professionals to educate the cancer professionals and the cancer professionals to maybe educate the dementia professionals. Like I say, this is building on the general level of awareness that's obtained through statutory and mandatory training, but it's more about special sort of specific advice and advanced training skills on things like communication aids, reasonable adjustments, the Mental Capacity Act, and also best interest decision would be beneficial. And that's what our staff sort of said that would be really helpful. And again, there's lots of examples of training resources that are already out there, such as the Frailty e-learning via the British Geriatric Society, or also the Dementia Friends through the Alzheimer's Society. The third recommendation was around education awareness raising for family and carers. This came loud and clear through lots of our experts by experience around actually how it was really important for them to understand what was happening to their loved one, understanding how things worked, understanding the pathways of cancer, understanding the pathways of dementia, and what things were also available to support them. Again, we have some good learning here from the East Cheshire Hospice End of Life Partnership and also the Alzheimer's Society, of where they provided information and support for carers and loved ones of people with dual diagnosis, but also dementia and cancer specifically as well. But suggested content from the engagement that we did was suggested around including things like an overview of cancer and dementia to help support increase that understanding of those loved ones and those carers, things like advanced care planning, power of attorney, end of life, access to national and local resources and things like that. But thinking about how we can utilise experts by experience to maybe co-design and co-deliver this information for other carers as well. And then the fourth recommendation was around dementia-friendly environments. So thinking about how environments are really important, how our buildings and facilities, what do they look like? Are they dementia-friendly? Do they support individuals entering into our services, and what that might look like? And again, there's lots of resources available nationally through the NHS around how you can support dementia-friendly environments. And then there were other recommendations for further scoping and exploration. So this is wider sort of stuff around the viability of patient passports to identify people with dementia or cognitive issues. And that might include guidance on things like reasonable adjustments. So we wanted to explore the current use of these passports. They're used in other areas, in other acute trusts for other types of different things. And there are some examples of things like the Alzheimer's Society utilising an All About Me document. And also in Liverpool University Hospitals, they have a red bag scheme for particular care home patients. So it's whether there would be something that would be adapted, an existing model, rather than creating something brand new, which might not necessarily get the buy-in or be as effective, but that's something to explore further to see if that is viable. And then the sixth recommendation is around scoping the use of flagging on electronic patient records to highlight dementia diagnosis or cognitive issues and potential reasonable adjustments that the individuals might have. And again, this is looking at what flagging options are available within the electronic patient systems. Obviously, they're quite vast, numerous across the Cheshire and Merseyside, and depending on the system that you're working in as well. But again, is there any learning from what others maybe do from other conditions as well, and whether this would be an option for utilisation in the future. And then we also included some wider system recommendations. We've included this in the completeness. As Katie's already mentioned, lots of the things that came across were systemic, and they're not necessarily just isolated to dementia and cancer, but we wanted to include these recommendations for completeness. So the first one is around assigning a named dementia specialist nurse on diagnosis. So it's very similar to how we have our cancer nurse specialists or our clinical nurse specialists assigned to cancer patients. Is there the possibility of doing this around dementia specialists as well? And then the final one is around mapping exercise for post-diagnostic support for dementia to support that navigation. So as we've already mentioned, the system is really complex. There's lots of different commissioning and funding arrangements, and it's not always easy to navigate those systems, but maybe something around mapping could include information about the national resources, helplines, that could be really helpful to be in one place and shared for those individuals. So this concludes the end of the the PowerPoint slides for the webinar. If you do have any questions, please can you put them in the chat, and myself, Katie and Catherine will be very obliging to help if anybody does have any questions. We can have a look at if there are any questions so far. So I've got one question. So firstly, you found if there were any issues relating to attitudes of healthcare professionals once dementia diagnosis is confirmed. In my personal experience, unfortunately, the healthcare professional was dismissive of the cancer because they had dementia. And then the second point is also, what do you think about dual diagnosis patients being allocated a health professional advocate, such as an Admiral nurse or Macmillan nurse, to help coordinate care and communicate with carers and speak up for them at MDTs? With current incidents and potential rise in numbers, it's logistically difficult with limited resources. And the third point is, where a lasting power of attorney, health and welfare, is in place, has this offset some of the communication difficulties? And if so, should this be proactively promoted? I'm going to look to Katie and Catherine for that.
I thought you might. Thank you, Jen. Do you want me to take, so I can see the question. So just to answer the first point about attitudes of healthcare professionals in relation to that dementia diagnosis, I think as a project team, we all had some anxiety about that actually when we went into the project. Were we going to find evidence that people were effectively being, and I'll use in air quotes, denied treatment or given lesser treatment because of their dementia? And I'm sorry to hear that it sounds like that may have been the experience of the person who's put the question into the chat here. I don't think we found any evidence that things were withheld because of a dementia diagnosis or that care was compromised. I think what healthcare professionals told us was that their approach was different, and they had to think very carefully about whether a patient was going to be able to tolerate diagnostic tests, whether they're going to be able to tolerate treatment. But also what plays into that was family carers, and whether family carers were also going to be able to, I'll use the word, comply with diagnosis and treatment journeys, recognising that the impact of those is significant at the best of times, and then adding dementia in as well. So we didn't encounter any sort of direct bias or discrimination, but I think all of the people we spoke to certainly acknowledged it was an awful lot more complex. Katie, is there anything you wanted to add on that?
Yes, I think we definitely had a lot of concerns about that, and there were concerns expressed by people that might happen, but no direct reports of that. So not just concerns expressed by patients and carers, but by concerns from other staff wondering whether or not they were making the right decision. So this came up around anxiety about decision making in light of complexity. One thing that's quite interesting is that when we went to visit where an Admiral nurse is embedded within cancer services, is that they'd identified some very clear strategies to support that and to challenge that decision making. So, for instance, one of the examples they gave was around skin cancer operations, and that people were having treatment, was not treatment denied, but were having a lot of concerns around general anaesthetic being administered. And there was anxiety of professionals going ahead with that treatment because of the impacts of the general anaesthetic. So because they had an Admiral nurse embedded, they were able to put lots of reasonable adjustments, and they've massively reduced the number of missions. They do it under local now because they're able to put all the appropriate things in place. So it just showed the benefit of when you actually have that expertise embedded, a lot of interesting solutions can be found, and you're sidestepping that problem. You want to speak to the second part? I mean, we'd love it if everybody got an Admiral nurse, and you're right to identify that this is going to be a massive resource heavy and unlikely in the current context. But it's good to note it as an ideal that people would be allocated an actual dedicated support. And I think the third point about the lasting power of attorney, I think this again speaks to one of the concerns we had, which is what happens to patients when they don't have this support network of a carer involved.
Thank you, Katie. Thank you, Catherine. I'm just going to pick up on another question. We mentioned care homes were engaged in well, they put research, it wasn't research, it was scoping exercise. So just we need to be clear on that. But in terms of the project, it was mentioned in the experience story as well. But are there any recommendations specific to care homes?
I think a lot of the recommendations would apply to care homes. And I think when we talked about some of that more in-depth training, we were mindful that we were not just talking about acute hospital services. I think it's really important we acknowledge that actually care homes as a collective are a huge end of care provider and a huge dementia care provider. So this piece of work really does matter in terms of care homes. They're obviously supporting a lot of people with dementia, and they will also be supporting people with cancer. I think the cancer care is probably a less recognised element of what care homes do. We would expect that community palliative care services would be able to support care homes. I know, again, I think some of what we picked up on the project was that sometimes is variable, can be patchy, and obviously primary care would be supporting as well. So although there aren't any care home specific, I think a lot of the recommendations would certainly apply to that setting.
Thank you, Catherine. And then I've got another question about, would it be helpful if there were elders champions in busy cancer MDTs to pick up patients with complex needs? Anybody got any thoughts on that? Either of you?
I think having access to that throughout was a theme that came out a lot. Sort of the idea of having someone who would coordinate, who would be aware of the complexity around frailty, and there were a number of recommendations that speak to that. I think.
Thank you. And then one final question, because I'm very mindful of time. How can you help those people whose partners are in denial that there's even a problem? Friends, loved ones maybe can see that there is a problem and speak out about it and say that the partner, we think you need to get help for whoever that person may be, but they just shrug because they're scared of the diagnosis and how it will impact on their lives. I think some of the recommendations are around things like challenging the sort of attitudinal bias maybe through things like training and education. So especially for professionals, that would be really, really helpful if we had cancer professionals training dementia and dementia training cancer. And also if one of the recommendations is about support and education for carers and loved ones as well. And that might also help, because if you're hearing it from an expert by experience who's lived and breathed this for several years, and they've got something important to sort of communicate and tell their story as well. So potentially we can look at how we can capture some of those stories to help support others to address those issues. Katie, Catherine, anything else to add to that?
I wish I could answer that really, really easily. And if I could, yeah, it would be great, wouldn't it? It is always going to be a challenge. I think I'm assuming, Julie, that the question that you raised is more around people who are avoiding finding out whether or not they have a dementia diagnosis. I think that's the one that a lot of people would acknowledge is particularly scary. I think just so that we give something practical on this, I think if people do have concerns, if you're in that situation or anyone else on this call is in that situation, the Admiral Nurse helpline that you can access through Dementia UK would be a really good starting point, if only to say, how do I approach this conversation? How can I start? Have you got any tips in terms of how do I broach the subject? So rather than just saying, yeah, it'd be great if we could, I think that would certainly be a good starting point, recognising it is a real barrier for a lot of people.
I think as well, if you're speaking to this from a clinical point of view, then if it's tipping over into safeguarding concerns and serious concerns, then there's safeguarding leads that may be able to support around identifying what could be put in place.
Thank you. I'm very mindful of time. We've come to the end. I really do apologise about the noise at the beginning, and I'm sorry if it did disrupt the beginning of the session. But yeah, thank you for everyone's time. And obviously, if you do want to contact myself, Katie, or Catherine, I think you've got my email from signing up, so you'll be able to contact me, and then I can put you in contact with Katie and Catherine if need to. But thank you very much for everything, and I hope you enjoy the rest of your day. Thank you.